Hello everyone and welcome to another video of medicine in 10 minutes or less. In these videos we summarize the most important points that you need to know while you are preparing for the MCCQE1 or the USMLE. In this short video we are going to talk about the most important things that you need to know about the treatment of hospital-acquired pneumonia and the ventilator-associated pneumonia. So grab your coffee and let's go. First, we have healthcare-associated pneumonia or hospital-acquired pneumonia. It is defined as a pneumonia developing more than 48 hours after admission or after hospitalization in the last 90 days. A much higher incidence of gram-negative bacilli is recorded here, such as Escherichia coli or Pseudomonas. This is very important because it will guide us in the treatment. Macrolides are not acceptable as empiric therapy for hospital-acquired pneumonia. The therapy has to be centered around therapy for gram-negative bacilli. We can choose one of these three groups: anti-pseudomonal cephalosporins like cefepime or ceftazidime, or anti-pseudomonal penicillins like piperacillin plus tazobactam, or one of the carbapinims like imipenem or meropenem. Regarding the ventilator-associated pneumonia, the ventilator interferes with the normal mucociliary clearance of the respiratory tract. The positive pressure is tremendously damaging to the normal ability to clear the colonization. That's why the incidence is as high as 5% per day in the first few days on a ventilator. To treat the ventilator-associated pneumonia, we have to combine three different drugs. First, we are going to use one of the anti-pseudomonal beta-lactams that we previously mentioned in this video. Plus, we are going to use a second anti-pseudomonal agent like aminoglycosides, like gentamicin or tobramycin or amikacin, or one of the fluoroquinolones like levofloxacin. Plus, we are going to use one of the methicillin-resistant antistaphylococcal agents like vancomycin or linezolid. Regarding the diagnosis of ventilator-associated pneumonia, we have 5 different ways. They range from the least accurate but easiest to do until the most accurate but most dangerous to do. First, we have tracheal aspirate, and then we have bronchoalveolar lavage, and then we have protected brush specimen, and then we have VAT, video-assisted thoracoscopy, in which we take a biopsy from the lung, and last, we have open lung biopsy, which needs thoracotomy. Before we finish, we have a few points that you have to keep in your mind. First, piperacillin and ticarcillin are always used in combination with a beta-lactamase inhibitor, such as tazobactam or clavulanic acid. Culturing an endotracheal tube is worthless. Always remember this. It's like culturing urine with a Foley catheter in place. It will always grow something because of colonization. Another point that we need to remember is that we don't use daptomycin for lungs. Daptomycin is inactivated by surfactant. That's why we don't use it in lung infection. The last point that we want to mention is that imipenem can cause seizures. So this is very important if you are treating a patient with a history of epilepsy, so you need to avoid it. Imipenem is excreted through the kidneys, so if the patient has renal failure, this can cause a rise in imipenem levels, leading to toxicity and the increased risk of imipenem causing seizures. Don't forget to like and subscribe to our channel to see the next videos.